typically a patient is seen by a lymphoma physician. In our institution, the CAR T-cell physician and the lymphoma physician are the same person. Now, what may change is what I talked about, is that if we are thinking that this could potentially be a CAR T-cell patient, whether or not it's a clinical trial or a commercial CAR T-cell patient, each one of those individuals is alerted that we have a potential CAR T-cell patient. So we have a nurse research manager for our CAR T-cell patients that are going towards a clinical trial, and we have a nurse case manager that navigates the commercial space for both our availability for axi-cell and T-cell. And so once that patient has been seen, and they often meet both myself or one of my colleagues, as well as the case managers for both settings, then it's kind of a parallel race. We're looking to see, are they eligible for clinical trials with certain eligibility that exists? Does their pathology state a diagnosis that we could use to get approval for CAR T-cell therapy on a commercial standpoint or in the clinical trial standpoint? We're then doing the same eligibility checks in the commercial setting that are often done in the clinical trial setting. Do they have adequate pulmonary function? Do they have adequate cardiac function? What is their renal function for when we're looking down the road for lymphodepleting chemotherapy? What is their prior history of their treatment for if we're considering giving T-cell when we may want to use bendamustine instead of Cytoxan fludarabine? Or what are their counts, and maybe we don't want to give lymphodepleting chemotherapy at all? And so we're having these discussions several times a week. And in fact, I try to meet with our CAR T-cell team at least every other week, kind of going over the list of the CAR T-cell patients, where they're at, where's their insurance approval, because I think that is one of the big things that we're getting into. And I should mention, the financial person is the next person we're calling if we're thinking down a commercial route. Is we need to really work hard. We're asking questions: who have we worked before from an insurance standpoint versus who is somebody that we're new working for, because we're really in the single payer contract arena right now. I think we'll move past that eventually. And we have to sort out the whole Medicare issue that has come to us, because I think we have to. It's to our patients and to the citizens of the United States. We have to figure this Medicare situation out for the benefit and for the potential benefit of this patient population. So we're many different streams of processing are going on. They're meeting with social work, because there is a commitment to time that they need to, if they're traveling from outside of the region of my institution. We have to be working on housing, of where they're going to stay after the CAR T-cell, where their caregivers are going to stay during CAR T-cell, and who can be their caregivers afterwards. And we tell them this can be a tag team event, right? It doesn't need to be one person who's the caregiver and one patient. It can be one patient and multiple caregivers, family, friends, and really trying to make this happen with the safest solutions that we can come up with. But we're thinking about that. Use the CAR T-cell. And then we have time, after the apheresis, where we had talked about, we're really thinking about how do we keep the patient's disease under control and keep the patient healthy, so that when the CAR T-cell, comes back, we're ready to start lymphodepletion and we're ready to infuse that patient. Now, in the post-infusion setting, at least at this point, our patients have been inpatient. Now, I think there's an experience with T-cell of giving the construct outpatient, and I think with improved understanding of the safety profile, with more experience in the commercial setting, maybe we will venture into the outpatient arena of giving lymphodepleting and giving infusion and seeing those patients daily to assess for onset of CRS or onset of neurotoxicity that would then require admission. But currently, right now, our patients for axi-cell, use are being are given their lymphodepleting chemotherapy as an outpatient and then admitted for their CAR T cell infusion. And they typically are spending anywhere from 10 to 14 days without any CRS or neurotoxicity in the hospital. If there are events of CRS, neurotoxicity, or other complications from the CAR T cell or unrelated to the CAR T cells, they may be in the hospital longer. And then once they're discharged and in the outpatient setting, they're being seen once weekly or twice weekly, depending again how their CAR T cell went, what their counts are they requiring transfusions because of cytopenias, and so really it's a very individual process in the inpatient duration of stay and in the outpatient intensity of how often they're being followed.
The workflow for CAR T therapy is perhaps similar to what it is for stem cell transplantation. At our institution, because almost all the patients we've treated so far have been on clinical trials, we're doing this with our clinical research office. We have a coordinator, a nurse coordinator, and several data managers assigned to this program. As we increase the number of diseases in which we're looking at CARs, to include CLL and myeloma, I think we're going to need more clinical research folks doing the work with us. As we evolve to commercial use of the drugs, which these products, I guess, we are evolving a coordinator. We are evolving a coordinator position that we've just hired to sort of coordinate all of the CAR T efforts and help be a funnel that takes some patients to clinical trials if the trial is available, and some patients to commercial product when that product is available. So I think our intent now is to have a coordinator for the whole program, and then if they're going to clinical trials, they'll go to the clinical trial person. If they're going to commercial, they'll be managed mostly by, in our lymphoma program, we have nurse practitioners associated with each faculty member, and so the nurse practitioners involved in treatment of lymphoma are going to be the ones that are going to be working on the commercial CAR T product. And those patients on clinical trials, we have a separate unit, our developmental therapeutics unit for early phase clinical trials, and we have nurse practitioners and nurses and ancillary personnel that are helping us manage those patients. So I think every institution has to figure out what works best for them, but I think having an intake person and a coordinator, at least one or two, I think, as the volume grows for this, is going to be extremely important. We also, because we get calls from around the world, because until now, although this is changing, there haven't been any CAR T trials in other places other than the U.S. China, in myeloma, I think, is an exception. We are getting calls from around the world from patients in different countries, and so we have involved our international office in that process, and they've been very helpful in trying to get through some of the problems we have. Obviously, these patients are coming without any insurance, and there's a huge copay that has to be figured out, and each institution has to work that out for themselves. I think that's going to change somewhat because there are some studies now just opening in Europe. I think Novartis is opening some trials in Europe, and so I think this is going to become more available.